Senior Territory Manager for Abbott Deep Brain Stimulation, my partner Taylor Humphreys. And it's our pleasure to host today's call with PAR and provide some additional education on deep brain stimulation. We're very lucky today to have our guest speaker, Dr. Gummadavelli. Dr. Gummadavelli is new to Denver. He is a functional neurosurgeon who completed his medical training at Yale, his neurosurgical residency at Yale New Haven Hospital, and most recently completed his fellowship in functional neurosurgery at Vanderbilt. He moved to Denver late summer and is now practicing at Littleton Adventist Hospital. And his practice focuses on providing neurosurgical treatments for patients with movement disorders, including deep brain stimulation, as well as epilepsy and other functional disorders. So with that, we're super excited to have you here today, and I'll let you take it away.
Great, thanks, Cindy. And can everyone hear me okay? Great. So good afternoon, and thanks for inviting me to join. My name is Gummadavelli. I'm a functional epilepsy neurosurgeon, as Cindy mentioned, and thanks again to the Parkinson Association of the Rockies for inviting me to speak at this webinar, allowing me to talk a little bit about deep brain stimulation in the surgical treatment of medically refractory Parkinson's disease, as well as just kind of give a brief primer on deep brain stimulation. I have no disclosures relevant to this talk. So just because I'm new to the area, as Cindy did, I'll just go a brief little introduction to myself about and how I got here. I grew up outside of Cincinnati, and then I went to Hopkins for undergrad, where I studied cellular and molecular neuroscience, and that's where I really began my journey on understanding and intervening upon circuits in the brain. And that's really what we do in a lot of functional and epilepsy neurosurgery. And so I continued this work in medical school and residency. That was at Yale and Yale New Haven Hospital. And really a lot of the work I did was in correlating brain physiology and signals with behavior. And we'll see how that's important in movement disorders and specifically in the treatment of Parkinson's. And most recently, I finished my fellowship at Vanderbilt University, subspecializing in functional and epilepsy neurosurgery. And I focused on procedures like deep brain stimulation in patients with neurosurgery. And now I'm very lucky to join Neurosurgery One, where Dr. Van Sickle has long been a leader in deep brain stimulation. And I work closely with Courtney Flynn, who's one of our PAs, who's integral to this team. And we're really working on improving and advancing the movement disorder and functional and epilepsy programs. So, like I mentioned, this talk is a brief primer on deep brain stimulation and surgical treatment of Parkinson's disease. And so we'll talk about what DBS is and what it's good for, what the data say it's good for, and what it's not good for, who should consider it and when, and how we specifically do it, how I specifically do it, and a bit about the surgical procedure. So, the first thing to address really at the most basic level is what is deep brain stimulation. And so it's a therapy, it's a surgical therapy with implanted electrodes to accurately deliver controlled electrical stimulation in structures of the brain that are involved with movement. And this electrical stimulation essentially overrides the abnormal and pathological neuronal activity within these brain regions to restore a more normal kind of brain rhythm and signal to hopefully restore normal function. We won't go through all of this history, it's much more detailed, but it's only really to show how far we've come in the treatment, in the surgical treatment of Parkinson's disease with DBS. Really the origins of it is as far back as the early 1900s, when people began with things such as removing and and using RF to burn parts of the brain involved in movement and tremor. And really, the advances came in the 1950s and 60s when they really started identifying nodes within the circuit that are important, and treatment there can in a more refined way improve the quality of life with patients with Parkinson's. And then in the 1960s, the discovery of dopamine, and in 1968, the discovery of L-DOPA, which is the ingredient kind of underlying Sinemet medication, very commonly used in treating and diagnosing Parkinson's disease, really changed the landscape of how it was treated. The surgical treatment kind of came back into interest really as we began to understand the movement circuit much better, and that was in the 1980s. And that was started with animal models, and then it moved into humans. And by the 1990s, there were much more in the way of reports and trials of using deep brain stimulation in some of these key nodes, which are, we'll talk about, which are important in the circuits related to Parkinson's disease, which can, they thought creates a reversible lesion. And that's really the key takeaway from this, is that we went from things that were truly irreversible to things that are, to a therapy that is reversible and tuned, that we can adjust the stimulation with time. Newer things such as a recent trial done in the 2000s, the early STIM, in which continually there are updates and progress shown that DBS plus medical therapy is better in quality of life and outcomes in patients, even with a short course of Parkinson's disease, and really better understanding how and when to do DBS. And nowadays, DBS is, a widespread and is a mainstay in the surgical treatment of medically refractory Parkinson's disease.
So someone asked, how has DBS changed over the past 10 years? I know people that have had DBS 6 years ago that did not respond well.
Yeah, that's a great question. And so it's changed in a number of ways. And as we go through the surgical kind of procedure, a lot of those specific steps have changed. And so whereas there was a time when we first started doing DBS, we'll talk a little bit about awake DBS surgery, but that was how it was originally started. So almost all DBS surgery started as awake surgery. And at that time, when DBS surgery was first starting, we didn't really know exactly what to listen for when we were listening to the neurons. Now, of course, we have a much, much better idea of how we know we're in a right trajectory in the right spot. We didn't know previously all of the side effects to look for or the potential comorbidities and how stimulation might affect those comorbidities. Now we have a much better idea of all of those things, and that's part of our preoperative workup as well as postoperative care. And then how we actually perform the procedure is changing and constant, and that's really something that we are constantly innovating on. And so there was a time when initially it was done with fairly large incisions, and it was done with a frame that was attached to the head while the patient was awake, and the frame was also fixed to the table. It could be somewhat uncomfortable for patients, and it was a fairly long procedure, and those are all things that have significantly improved. There are ways to do it both awake and asleep that we'll touch on, that are much more comfortable for patients if they are awake. And there are options. So if patients prefer not to be awake and we think that it's a good option for them, then they can be under general anesthesia and asleep. And so with that, and if we're not having the patient awake and listening to cells, then we also have much better ways of targeting the electrodes with imaging. And so, along with the advances in physiology and technology have also come advances in neuroimaging. And so those advances in understanding what are the locations within these specific nuclei that are best for controlling tremor and the motor symptoms of Parkinson's have improved, and that's something that's continually being improved. hopefully I answered some of that. I know it's a kind of complicated answer, but it's there's actually innumerable ways in which it's changed even within the last 10 years. All right, and I'll keep going. So the next kind of thing to address is, what is DBS good for? And one of the first things, whenever I meet a patient in the office is we talk about what are the symptoms that are affecting their quality of life the most, because I want to make sure that the symptoms that we can address with surgery are symptoms that would be important to them. And so the short of it is that it's the motor symptoms of Parkinson's that respond the best. And these are really the symptoms that respond to medications, or at least in the beginning they do. And so these kind of symptoms are the hallmark symptoms of Parkinson's, which are tremor, resting tremor, rigidity. And then the issues with movement, whether it's a slowness of movement, which is bradykinesia, or the loss of movement, which is akinesia, or involuntary movements. And that often happens with doses of medication. These are dyskinesias. The things that DBS is not as good for, or at least what the data show that it's not as good for, are things like speech dysfunction, swallowing issues, issues with writing, especially very, very small handwriting, or issues with posture and gait. It's not that DBS has no chance of improving these, but the data have shown somewhat mixed results. And so we're much more careful when we advise patients about this, especially if this is the overriding issue for them. And so this is something that, again, we're still better understanding if there's locations or physiology within these targets that can help address some of these issues. The other thing I also always tell patients is the cognitive aspects of Parkinson's, as well as the progression of Parkinson, isn't particularly affected by deep brain stimulation alone. What we do know is that patients with deep brain stimulation overall do better even as the Parkinson's progresses, and this is often because the stimulation can be adjusted over time. So these are some slides that just show really kind of landmark results from large studies that kind of drive home some key points about what DBS is good for. And one of the key things is that the Parkinson's patients often experience on-off periods, so time in which they have good effects with their medications, the on time, as well as off periods where they don't have good effects from medication. And there's on time with dyskinesias in which there's almost excess medication causing inadvertent movements, and on time without dyskinesias. And so what we're trying to hit is the sweet spot where there's on time without dyskinesias. And this large study really showed that both with treatment in the subthalamic nucleus as well as the globus pallidus, two of the main targets used in Parkinson's disease in the brain, have a significant improvement with just 6 months of stimulation in terms of on time without dyskinesias, go from about a quarter of the time, and this is based on patients' diaries, to about 65 to 75% of the time. The next thing is that before surgery, these on-off fluctuations tend to be much more dramatic, whereas stimulation tends to level these fluctuations out. And so it's not that the fluctuations go away altogether, but the amplitude of the fluctuation is a lot lower. And the third thing to understand is that these are long-lasting results. And so this is a study where looking 5 years out after DBS treatment showed that the improvement in these motor symptoms, the tremor, rigidity, and issues with movement, improved on the scale of around 70 to 80% for tremor, up to 5 years lasting throughout that period, around 75% for rigidity, as well as between 50 to 60% for issues with movement. So the next kind of point is who should get DBS and when should they consider getting it? So the surgical candidates that we often discuss are patients with idiopathic Parkinson's disease, so without a cause for why they have it, without a clear cause anyways. And with the classical symptoms such as resting tremor, rigidity, and issues with slowness of movement. Often the symptoms are for at least over 4 years, and patients are responsive to medications like dopamine-containing medications. And this is a good prediction of improvement after DBS. These patients often have dose-limiting side effects, so they have dyskinesias or inadvertent movements with medications, and they don't have they don't have Parkinson's plus or other Parkinsonism syndromes. So some of these include progressive supranuclear palsy, Shy-Drager syndrome, and multiple systems atrophy. These syndromes don't respond as well with deep brain stimulation. And patients with cognitive impairment, so forms of dementia, or with mood disorders, so we do this as part of the preoperative screening because we know that it can impact both complications as well as responsiveness to deep brain stimulation. And so every patient undergoes neuropsychiatric testing as part of the preoperative workup in order to assess for some of these factors. The other issue is not only who, but when when DBS should be considered. And so the short of it is really when patients experience troubling motor symptoms despite pharmacotherapy and optimized pharmacotherapy, and usually that's with a neurologist or a movement disorder neurologist. These patients often have issues of the medications wearing off, so they have off periods resulting in worsened symptoms. They may have excessive amounts of medications in their system causing dyskinesias. They have those motor fluctuations, so dramatic changes in their symptoms, and have increasing periods of off time, so worsened symptoms. And other issues that cause severe quality of life impairment is refractory tremor. Even if other symptoms are more controlled, the tremor alone can cause significant worsening in quality of life. The other thing that has been recently shown and been much more researched is understanding that the early treatment of the motor symptoms of Parkinson's is important in maintaining the quality of life for patients. So very early on in the disease process, patients are often able to be controlled with medications. And it's really in that middle sweet period when the medications are starting to wear off, but quality of life is still maintained. That's when we are finding that that's the most kind of opportune time to intervene and undergo things like surgery. Whereas later in the disease process, the quality of life of patients is often more impaired than we're able to help with surgery. And at that point, we really have limited amount of things that we can help with. And patients are often very poor surgical candidates at that point too.
Someone asked, am I a good candidate if I previously underwent focused ultrasound for tremor-dominant Parkinson's disease? Yes,
so we have done deep brain stimulation in patients that have undergone ablative procedures. So whether that's with radiation like Gamma Knife or focused ultrasound. And so, yeah, they're absolutely still candidates. So next, actually, that kind of leads up to this, this process of how we evaluate and kind of undergo the process of getting DBS started. So the first thing to kind of understand is that it's a large and multidisciplinary team that's looking out for each patient. And that's important to me because as a surgeon, my meeting with the patient is much shorter than the disease course. And so often a patient's primary care, their neurologist, they know them much better and they know how their life has changed. And so that, we rely on that kind of input to understand how the quality of life is impaired. And so all of these folks are involved in terms of the decision making. And so apart from the neurosurgeon, neurologist, primary care, there's a neuropsychologist, as I mentioned, that meets with every patient. There's neuroradiologists that review the imaging, and these are specific neuroradiologists that have experience in looking at the brains of patients with movement disorders. They often meet with physical therapists and occupational therapists as part of doing standardized scales for Parkinson's. And as right now, we have involvement from folks from industry and research. That can be important in getting patients the best devices and the best care, but also advancing things for the future. The surgical pathway kind of involving this whole team really starts with a neurology or neurosurgical referral. And so based on the surgical consultation, we can gather all of the things needed for preoperative evaluation. And so this usually involves an MRI, a specific MRI sequences, a neuropsychological evaluation, as I mentioned, and formal scales for specific to Parkinson's disease. And so this is the UPDRS, and it's done with and without medications. And this really helps us evaluate the responsiveness to medications and gives us an indication of how good deep brain stimulation might be. It often involves a multidisciplinary review, at least with the neurologist and neurosurgeon, often includes many more members of the team. And then, presuming that we proceed to deep brain stimulation, it involves a preoperative visit and then the surgical implantation, which we'll go through. And then the kind of last step is programming and maintenance kind of therapy, and that's often done with a neurologist. The target sites, some of which I mentioned a little bit before for deep brain stimulation, include the thalamus, which is predominantly actually used for essential tremor, but in patients with tremor predominant Parkinson's, as someone who asked the question, we use a nucleus in the thalamus for this. Then there's other nuclei such as the subthalamic nucleus and the globus pallidus, pars interna. So these are key nodes within the motor circuit that are affected by Parkinson's disease. And we have found that deep brain stimulation here significantly improves the functional status for patients. And so the selection of the target is driven by the patient's quality of life and their goals, the neurologist, the neurosurgeon, many members of the team. And based on those symptoms and goals and the functional status, we select the ideal target for the patient. And then lastly, I'll kind of talk in detail about the surgical procedure as well as risks of the surgery. And so there are many, many ways to place deep brain stimulation electrodes. And so it's rare to find any two surgeons, much less any two programs, that do it exactly the same way. So there's two ways that I'll describe, that I'll offer for how we do deep brain stimulation electrode implant. One is using a 3D printed patient-specific frame called the StarFix platform, and this is used for both awake and asleep surgeries. And the second is a method that we'll be offering in the coming months, and it's using an intraoperative robot, which is shown in the lower picture, and it's called the NeuroMate robot. And it assists us in actually deciding the location to place the electrode, and it's used primarily in asleep neurosurgery. There's slight differences in the procedures themselves, as well as the amount of hair shave needed and kind of some of the technical nuances in terms of if the head is fixed to the bed or not between these two procedures. So in the StarFix platform, we need actually 3 procedures in order to complete it, whereas with the NeuroMate procedure, it's 2 procedures. With the StarFix platform, there is 1 extra procedure, which is the bone marker placement, which I'll describe in a minute. And it requires a full head shave, whereas with the NeuroMate robotic placement with a sleep surgery, it's a much more limited haircut, if that's something that is crucial to the patient. What we have found is, based on the kind of goals and the comfort of the patient, we're able to tailor the surgery and the surgical approach to fit the kind of the needs of that specific patient. The other thing that has often been talked about is awake versus asleep surgery, and I don't think that's necessarily a fair way to look at it. I think that oftentimes it's addressing what is the best approach for that patient and the specific target within that patient's brain and the symptoms that that patient is experiencing. And so in some patients with very typical brain anatomy, with very good imaging, with symptoms that awake testing would not necessarily make major differences in their care, that a sleep surgery may actually be a faster, better, more accurate procedure for them. In patients in which awake testing really would make a difference in which electrode will help them the most, then I think it's nice to have that option. And so, as I kind of show in this little table, there's benefits and drawbacks in each. With awake surgery, it's done with local anesthesia, and we're able to use an awake patient to refine the specific contacts and electrodes that will help the patient the most. So we're able to see, and the patient themselves is also able to see the improvement intraoperatively to their symptoms. And we can also test for side effects, things like paresthesia, so numbness or tingling, or involuntary motor contractions, or trouble with speech, things that could be very disabling to the patient after if we didn't know about that and could move the electrode intraoperatively. Whereas with a sleep surgery, the patient is obviously under general anesthesia. In patients in which they're essentially very anxious and would be very anxious with awake surgery, then sometimes this is a much better option for them based, again, on their symptoms and target. With a sleep surgery, as I've mentioned, we had great improvements in neuroimaging. And so we can target based on those MRIs. And often that leads to a shorter procedural time. But like I said, one of the drawbacks is we're unable to test for efficacy or side effects intraoperatively. However, with new technology in devices, things like directional electrodes, we're able to minimize side effects to a large degree. So we'll go through some of the details of the procedures. And this is something I do in detail in the preoperative visit for each patient. And so if we do the procedure with the StarFix platform, the first thing that needs to be done is a bone anchor implantation. And so this is typically done 1 to 2 weeks prior to electrode surgery, electrode implantation. And so with that surgery, prior to actually coming to our radiology suite, the entire head is shaved. The patient comes to the radiology suite and gets general anesthesia. And then we make 4 very small incisions, about 5 millimeters each, and put these very small screws actually into the bone and close each incision with a dissolvable stitch. and then the patient gets a CT and an MRI under anesthesia, so the any tremors or movement issues don't affect the quality of the scans. And then the patient actually wakes up and goes home that same day. Since the actual surgical risk is pretty low, there's a very tiny risk of infections to any of those bone anchor sites, and the main risk is really getting general anesthesia. So after the patient goes home, I take a look at the imaging that's done, and we create the perfect trajectory, and I'll show kind of how that's done. The second kind of stage is the electrode implant. And so the goal is to place the electrodes as accurately as possible, and based on the computerized plan that we have either in the StarFix system or that we plan with on the robotic planning software. And so most commonly, we're able to do both sides in a patient's brain at once, and usually that's the right thing for most patients. Less commonly, we do only one side or one side at a time. The surgery itself usually takes about 3 to 4 hours, and then the patient goes to the recovery area. They get a CT scan post-operatively, and they spend on average about 1 night in the hospital and go home the following morning. And like this CT scan shows, the electrodes are tucked kind of above the ear on either side. And this kind of shows in this area under the skin, over the muscle above the ear.
We do have a couple of questions.
Sure.
Someone said, when I received my DBS surgery, at that time, the MD told me there is a danger of melting the wires in together. This can occur in some dental problems and if the patient has neural images. I've been trying to find that citation. Do you know what that could possibly be?
I haven't heard of, there's, with any of these procedures in which we place hardware and wires, there's a small risk with future procedures of injuring those, the insulation or the wires. But, that's another thing that's really changed with time with DBS surgery is the quality and a lot of the characteristics of the hardware has improved such that it's much harder to injure. And we've learned what kind of technologies we can use to avoid injury to the hardware, such that those kind of things are pretty uncommon nowadays. I haven't ever seen wires that melt or the insulation that melts. That's pretty uncommon.
Okay. Someone else asked, I think this was in reference to your previous slide, how many contacts are used? Also, is DBS a one-time opportunity or can it be reworked, i.e. change the placement of the contacts 5 years later, hypothetically?
Yeah, that's a really good question. It's pretty nuanced. And so there was a time in which, so starting with the kind of simple that you were asking about how many contacts. So this is something that is undergoing innovation. It used to be that each electrode had 4 contacts, and now where the middle contacts, so the second and third contacts within that 4 electrode array are split up into thirds. And so there's a total of 8 electrodes or 8 contacts per electrode nowadays. And that's what allows for directional steering of the current. And that helps improve symptom relief as well as avoid side effects. And so your second question was regarding if there's opportunities for multiple DBS electrodes or changing the position. And this is something that we're seeing more often nowadays, where patients may have insufficient symptom relief despite adequate placement or inadequate placement of their electrodes. And so there is, based on where that electrode is placed, in some cases, we're able to move the electrode to a more adequate place And often that means doing an awake surgery so that we're sure, because the anatomy has been distorted by previous surgery, or it can mean using a completely different nucleus, a different target, in order to try to control the symptoms better.
Those are all the questions for now.
Perfect, great, I'll keep going. So this is just a brief schematic that again overviews the process of electrode placement. And so it starts with imaging and planning. And so we plan the perfect trajectories into the brain. The second is the majority of the surgery, where we actually open a small incision. We place the electrodes. And then the third major step is verification. And so whether that means doing awake testing or using an intraoperative imaging in order to check the location of the electrode in a sleep surgery, for example, and then we secure the lead and then close the incisions. And so this is a little bit more detail, and this is showing how we do it with the StarFix platform, for example. And so when the patient comes back to the operating room, the hair is trimmed, whether in the StarFix platform it means a full head shave, or with a robot it's a minimal hair shave. The frame is placed, so whether it means that they're the patient-specific 3D printed frame, which is shown on the lower right panel here. This kind of H-shaped piece from the software is 3D printed, and I have an example here, and it's kind of shown like this. And again, this is something that we kind of go through in detail, and patients actually take a look at and get to feel during the preoperative visit. We place that on the patient, or in the case of if we use an intraoperative robot, the patient's asleep and then we align and register the robot. So based on these stereotactic equipment, then we are able to make an incision. Usually the incision is about the length of my pinky, a few centimeters long, one on each side, presuming that we're doing both sides. And we create a burr hole, which is about a 7 to 8 millimeter a radius, so about a 1.5 centimeter wide burr hole is made. If we're doing an awake surgery, once we start putting in electrodes, microelectrodes into the brain, we actually listen to the brain first, and then we stimulate in order to try to improve symptoms and make sure that we minimize side effects. Once we find the perfect location, or in a sleep surgery based on the imaging, we decide the perfect location and we actually put in the electrodes. And then if we're doing an awake surgery, we wake the patient up and then we do more testing. And in a sleep surgery, that's when we would bring in the intraoperative imaging, like the CT scanner, and verify that the electrodes are in a perfect place. And then after that, it's pretty similar. The patient gets sleepier, or in a sleep surgery, the patient obviously stays asleep, and we secure the leads in place with special little caps that also cover the burr holes. And then we tunnel the tails into that location above the ear, under the skin, and then we close the incisions and the patient goes to recovery. Like I mentioned, they get a CT scan after the surgery in order to look for any complications and make sure the electrodes are in the right spot. And then they spend one night in the hospital typically. This is just a very brief example to show when we do awake surgery, what are we looking for? And we won't go into all the details here because there's kind of a lot to go through, but just to say that there's specific characteristics or signatures of each of those locations. And we're able to capture, in some cases, we're able to actually capture cells that show the tremor, for example. And that's how it gives us some indication we're in the right spot. And then we also do stimulation testing. So we inject small amounts of current, and then we ask the patient to do certain things, whether it means reaching out and touching our finger, things that they would normally have some trouble with. And then we look for the improvement in these symptoms, while also testing for side effects.
Someone asked, can the wires be seen by others for those that are bald and have TBS?
So that's also that's a good question. So The way we typically implant the leads and the wires as they go behind the head, it's very uncommon. Whereas previously the profile of those caps used to be kind of much higher, they're actually much less noticeable now. And in cases in which patients are bald or if they have very thin skin, what we sometimes do is actually drill the outer table of the skull in order to reduce the profile so that there's actually barely any bump noticed from the cap. The wire, the one place where people may feel a little bit of a bump, and sometimes, and very rarely it's seen because it's behind the hairline, is the location of this connector. And that's a little bit of a bigger bump than the very thin wire. And so the wire kind of, it runs from the electrode to this connection where there's a little bit more of a bump, and then it becomes a thin wire again, which we connect an extension to and connect to the battery.
That's it for now.
Okay, perfect. And so yeah, that's perfect because it brings us to the last stage of the surgery before we turn it on is a week or two after the electrodes are placed. The patient comes back for an outpatient procedure where we attach the lead extenders and place the battery. And this surgery itself usually takes about 60 to 90 minutes. It's done under general anesthesia, and then patient goes home that same, usually by the afternoon. The main things that we worry about during this surgery are bleeding within the pocket in the chest specifically, and infections down the road. So typically we allow this last stage to heal at least for 2 weeks before the whole system gets turned on for the first time and patients undergo initial programming. And that's usually one of the longer visits, the initial programming, because that's when either with our team or with the neurology team, the patient undergoes really electrode by electrode, contact by contact, going through a number of different possibilities in order to try to find what specific stimulation paradigm will help them the most. So as with any procedure we do, there's going to be risks associated with it. The biggest things that we are concerned about, and this is why we do the whole procedure in such kind of an elaborate way, is to avoid any injury to the brain or blood vessels surrounding the brain. And so if there's any issues, especially with the blood vessels, can lead to things like bleeding within the brain, bleeding around the brain, or strokes. So when the parts of the brain aren't getting enough oxygen. And the majority of the time, and this is part of the reason we do the postoperative CT scan, is to see if there's any such complication. Most of the time, even if there is blood, it's a very, very tiny amount, and patients often don't notice anything beyond maybe a tiny headache. But they don't have any neurological symptoms from it. Very rarely patients do have neurological symptoms, but they're usually transient in the sense that the body recovers and the deficit goes away, usually on the order of in a few weeks. Very rarely has been reported, I haven't seen anything like this, but there have been reports of catastrophic kinds of hemorrhages with deep brain stimulation electrodes, and that's exceedingly uncommon. And really, as technology has improved, it's been shown to get better and better. And so typically we quote around less than 1% per electrode placed in the brain has a risk of any kind of bleeding event. Other things like confusion, delirium are again really based on things like age, comorbidities have increased the risk of those things. But for most patients, it's pretty low risk. The biggest things that we worry about kind of long-term are issues with the hardware, infections. And so that's why in many of these cases, we have very kind of strict protocols to avoid anything like infection, because this is, after all, a foreign body that's within the human. And so any infection can seed it and can travel along it. And so, you know, obviously, if there's any signs of infection, especially close to the electrode, we warn patients that, you know, it means often taking the entire system out, because, you know, we don't want an infection to go into the brain and cause an abscess. There are patients that I've seen that have previous infections that they were getting so much benefit from DBS that they get the infection treated for a few weeks, often a few months, and then they go through the whole process again because it was helping them that much. In terms of issues with stimulation, it's pretty rare that we can't adjust the stimulation parameters or which contacts or the direction of the stimulation in order to overcome any of the side effects of stimulation. And so often any of these symptoms like numbness, tingling, issues with speech, muscle contractions, changes in vision are reversible and can be adjusted based on adjusting the stimulation. And the last thing is, you know, with the most of the batteries that we place, they are what we call primary cell, and so they're not rechargeable. And so that means that at some point their battery gets to the end of its life and we have to replace the battery. And so that is a very short, very common procedure. Often people think of it in the same way as they do of a pacemaker change. It takes about 30 minutes to 1 hour. It's done under general anesthesia, and patients go home the same day. They're on postoperative antibiotics and pain medications for just a few days after, and then we turn the generator back on to the regular settings, usually in the operating room. And so kind of the takeaways from this, this little primer on deep brain stimulation is that early consideration of deep brain stimulation for patients with Parkinson's is important for maintaining quality of life. And then the preoperative surgical workup includes a large multidisciplinary team, and it evaluates each patient's individual characteristics in order to help them decide, hopefully, you know, if it's the right thing for them, where in the brain might be the best target, and how to achieve that. There are multiple implantation techniques, both asleep and awake forms of the surgery. And, you know, my kind of approach to it is that we need to personalize the technique to the patient's disease, the targets involved, and the patient's preferences. And there's a high likelihood of benefiting, especially the motor symptoms of Parkinson's disease, with this treatment. And so with that, I'd like to thank, you know, the hosts of this, the Parkinson's Association of the Rockies. Thanks to Abbott for inviting me for this as well. And the hospital that I'm at is at Advent Health. Littleton is where we perform these procedures. So with that, I'd like to thank everyone for their attention, and I'll take any questions. Any other questions, I should say.
Someone asked, is there a maximum age limit for DBS?
That's a good question. That's something that's been debated, and as of this point, there is not. There's, it's really it's on a patient-to-patient basis, an evaluation specifically on their quality of life, on their symptoms, their disease progression, and their comorbidities and their other health.
Okay.
Last year, we actually, I think we did DBS in a patient in their 90s, early 90s, because they had such a good quality of life, and there was significant, you know, improvement with DBS. So I think there's not purely the number is not a strict cutoff.
It seems like Phil has had his hand raised. So Phil, you're unmuted. Did you have a question?
Yeah, I was just wondering if we could get a copy of the presentation.
Yeah, sure. I can figure out how we can make sure it's all compliant, and we will try to send it out.
Okay, thank you.
Sure.
Okay. Are there any concerns with physical activity causing displacement of the contacts or any other issues?
So it's pretty rare that trauma will cause issues with the leads themselves, just because the entry points are usually on the top near the front of the head. There have been cases, unfortunately, if patients hit directly onto that location where the leads may fracture or the caps may fracture. That's very, very uncommon. I haven't ever seen a lead that moves purely because of trauma. It's usually something external, and that's usually fixable. Anything beyond the lead extension and the battery can be fixed independent of the lead itself. Any injury to the lead more proximal to the connector, so closer to the brain, that's when it becomes complicated because that's all connected to the portion that actually goes within the brain. And so then the risk is higher if we wanted to kind of fix that. But then that again is pretty uncommon. Much more commonly, sometimes we'll see that because of some trauma, the way that the battery is attached above the muscle becomes loose, and sometimes patients become uncomfortable if it flips or moves. And so usually with the next battery replacement, we can adjust that.
Great. Someone asked, do you still recommend getting physical review in airports instead of using the X-ray and other machines?
So there's usually not an issue. Any patients with these kind of implanted medical devices get a card, and perhaps Cindy or Taylor can talk more about this. They get a card, and as far as I know, there's no issue with travel and using the scanners in airports. Yeah.
We typically just tell patients to say that it's like a pacemaker because TSA will understand that a little bit better. And then they'll just have the card, and then they're allowed to go through the machine where you have your hands up instead of, you can go through where you get wanded as well, but they will pat you down. So it is okay to go through the big machine. You don't have to necessarily go through the metal detector.
Great. Someone else asked, will Colorado Motor Vehicle be notified to start driving restrictions?
No. So, I deal with the driving issues mostly actually with epilepsy patients. What I tell patients after deep brain stimulation surgery is, especially when you're on pain meds for the initial 2 weeks or so after the electrode implant surgery, obviously no driving. And then try to take it easy for about a month after. So usually folks have help and able to have someone help them drive. But after that, there's really no restriction on their driving, and so we don't need to report it. And as far as I understand, in Colorado, it's not a mandatory report. So even in cases, we don't tell the DMV or anything like that that certain folks can't drive. But I do recommend after any of these major surgeries that patients you try to take about a month, of taking things generally easy, which includes not driving.
So Grace has her hand raised, so I'm going to unmute you, Grace. You can go on ahead and ask your question.
Yes, I'm 60 and I was diagnosed with tremor dominant Parkinson's in early June. My doctor, neurologist, is recommending deep brain stimulation as soon as possible, and I've consulted with your partner, Dr. Van Sickle. I'm about to start my evaluation. You mentioned the study that it works well for 5 years, but realistically, how long can I expect to have relief from my tremor?
So I think it will help kind of indefinitely, but often what we see is that over time, as disease progresses, because like as I mentioned, the deep brain stimulation doesn't affect the progression of disease. So over time, it will seem as though the tremor comes back or gets worse. And often those are the times where, as long as it's within the range of the, and where, you know, based on where the contacts are and the range of stimulation, the neurologist can change the stimulation parameters to better capture the tremor. And so it's actually much longer than 5 years.
Thank you.
Yes, of course.
Someone asked, my surgeon has left medicine. Do you accept patients from other surgeons? At what point does the patient need to get reevaluated?
So we do accept patients from other surgeons, and you know, it's really dependent on how long it's been since the last MRI and neuropsychiatric evaluation and formal testing of their Parkinson disease. So it's really, you know, if it was done fairly recently, we can often use that same information to help make decisions. But if it has been quite a while, then I think it's often in the patient's best interest that we make the appropriate decisions to redo some of that testing.
Great. Someone asked, can you show us a sample of the generator?
A sample of the generator, I do have one here. This is oh. If you give me 1 second. So this is a sample one here. I'm looking, I have a few samples around my office, and I wish I could find the perfect one to show you, but it's about, you know, a few centimeters wide and tall, usually about 1 centimeter to 1.5 centimeters thick. And in most patients, it's actually well hidden, just underneath the subcutaneous fat. In very, very thin patients, I do warn, like if it's going to be a little bit more prominent, and then we sometimes tailor where exactly we put it if patients are particularly concerned about that.
Someone asked, any complications associated with scuba diving?
Not that I know of. You know, generally after any kind of brain surgery, you know, there are small amounts of air around the brain. And so obviously immediately after, I wouldn't recommend it. You know, but by the time folks heal up between 6 to 8 weeks after, a lot of that air has dissolved. And so there's not any issues with activity restrictions by that point. It's really, you know, I would be more worried about the incisions long term if there's a large exposure to being submerged in water. And so you'd want to be careful with protecting the incisions.
Then someone else asked, how long is this process overall?
Yeah, that's a great question. And so it depends on the method of implantation. And so with this StarFix platform, where there's 3 procedures, what I usually tell people from the date that we do the first procedure and the imaging to the date in which the whole system gets turned on is about 2 months. So between every procedure, there's about 1 or 2 weeks. And then we let everything heal for usually about 2 or 3 weeks before we turn it on.
Great questions. Any other last questions before we finish, or anything else, Cindy or Taylor, you want to add?
I've been muted. I'm muted.
No, you're good now.
Oh, good. Hey, I was just going to say, if somebody wanted to schedule an appointment with you, Dr. Gummadavelli, what's the best way to connect with the office?
Yeah, let me go back to the first slide. It has our number and our website. And so, you know, obviously, if you're meeting with your primary care or your neurologist about the Parkinson and you're interested in deep brain stimulation, they'll be able to refer to us directly at Neurosurgery One, and we'd be happy to see. Otherwise, you can always call, make an appointment yourself, and we'd always be happy to talk to patients, even before they are necessarily ready for surgery. But if they are just thinking about it, that it might be something that we can start talking about and decide if or when we might need to do evaluation.
Great. Thank you.
Sure.
I guess there is one more question. What would cause inflammation in or near the brain? How would I get rid of it?
Yeah, so is this in terms of after deep brain stimulation implant?
Yes.
Yeah, so we rarely see that. Oftentimes, it's one of the risks of surgery is seizures, and that's often how we end up finding if a patient has inflammation or they might have some kind of mild neurological deficit. Usually, it's treated with steroid medication, and that plus time usually improve the swelling around the electrodes. What people have started to consider is it probably happens a lot more frequently than we recognize, because most of the time we don't get recurrent long-term imaging on these patients. And so it may happen more frequently than we think, but not cause any problems. And we only find it in patients that are having issues. But the short answer is usually steroids in time improve the swelling surrounding electrodes. Very rarely, like if there's an underlying infection, sometimes swelling is the first sign.